Welcome to the Manifestation Lab. This is your host, Kelly Howe. From the grounded science to the mystical and unseen, we're investigating this big experiment we call life and finding what really works when it comes to manifesting a life that sets your heart and your soul on fire. Welcome to the lab. Okay, I know I always say this, but I'm really excited to bring you my guest today. You guys know that I am so passionate about the mind-body healing process and how important it is to pay attention to the signals coming from your body because those are signs from the very deep subconscious and there are ways to release and heal them. You all know that I'm obsessed with tapping. It's my go-to technique, but it is not the only way to get into those deep subconscious spaces. Today we're talking about somatic experiencing. I'm excited because I don't actually know a lot about this technique. Today I'm talking to Dr. Chris Lawrence. She is a clinical psychologist and somatic experiencing practitioner, as well as a mom, partner, knitter, camper, hiker, just super cool lady all around. Chris received her Ph.D. from the University of Missouri in clinical psychology with an emphasis on children and families. This is one of the huge reasons I wanted to talk to her because I know so many kids and adults obviously are struggling right now, and we all need tools outside of the norm, maybe things we haven't tried before. In 2016, Chris began studying somatic interventions for anxiety, trauma, and depression. From the beginning of the training, she says she recognized that she had been looking for a very different perspective that she started to finally get through her somatic experiencing training. She now leans into the belief that mental health and, quote, dis-ease are the result of context, environment, and culture. She now looks at symptoms as expressions of distress that are a result of the environment that feels unsafe. Yes, yes, yes. Oh my gosh. We all need to pay attention to what feels unsafe and absolutely what felt unsafe in our upbringing. These environments can be prenatal, familial, neighborhood, work. Really doesn't matter. It can be absolutely anything. And these unsafe environments result in what we know as symptoms. Treating these symptoms involves reorienting towards resource, nature, pets, support of others, movement, just to name a few, and slowly unwinding the nervous system to allow it to return to its natural state. Chris has also trained with Kathy Kane and Dr. Stephen Terrell to use therapeutic touch in the treatment of developmental trauma. And Dr. Chris Lawrence is an ongoing teacher and learner in the area of nervous system regulation. She is speaking my language. I think everybody should have to take a course in school about nervous system regulation and, self-help techniques to learn how to do that. She's so passionate about talking about resilience and the impact of traumatic stress on our bodies. Her newest passion is helping parents and babies work through birth trauma. And I don't know if you all know this. I'm not sure if I've talked about it, but I was a labor and delivery nurse for 10 years. So we had a lot to talk about. We really just scratched the surface with that subject. Hopefully I can have her back on and we can go deeper with that. But birth trauma is a very real thing. Both as a baby going through it and holding on to that subconscious trauma, and also as a parent, of course, it can be very traumatic. So, of course, not just parents too. I'm thinking about grandparents and other caregivers. It can be super scary. So Chris founded Chris Lawrence and Associates, a mental health and private practice that employs over 20 clinicians. She is here locally in Columbia, Missouri, where I'm located. She works directly with clients, provides supervision to students and developing clinicians. And, she's just so passionate about teaching these clinicians and helping them get to the tools that, took her a long time to find, and helping them get to these tools that are just so impactful and life-changing. Chris is also the founder and director of HeartSpace. HeartSpace? Isn't that funny? I got an accent all of a sudden. Founder and director of HeartSpace Clinic, which is a nonprofit organization that offers a wide variety of services focused on building resilience in the face of traumatic stress through interventions that target the nervous system. One of the things that she teaches and that she utilizes with people is called the Safe and Sound Protocol, developed by Stephen Porges. The Safe and Sound Protocol, we talk about that a little bit. It's so interesting. She says this is an auditory intervention that was developed by Stephen Porges, who is a neuroscientist. The intervention is based on a couple of facts. One, our hearing is supposed to mid-frequency sounds that are associated with certain music and human voice. And 2, that low-frequency sounds indicate danger to the nervous system. Think growling, for example. So really, really interesting stuff. We're going to get into that. They're having incredible success with people for things like anxiety, and she even says that over the last 3.5 years, they've seen a decrease in anxiety, depression, and trauma symptoms in 50 to 80% of their clients. Incredible, right? They also have funding for Boone County's Children's Services to offer that treatment for free at a very reduced cost. So if you fall into that category or wherever you're located in the world, you may want to check out Stephen Porges' work, and the Safe and Sound Protocol is so interesting. This is a great conversation, and one of my favorite parts of it is really just learning about Chris and her history, where she is now, but also where she's been, and how, as a traditional clinical therapist, as a psychologist, she ended up in something like somatic experiencing. Her story is really fascinating. And I know I always say this, but I think you guys are going to really, really enjoy it. So sit back and enjoy. I had such a great time talking to Chris, and I really hope I can get her back on for another chat so that we can go deeper into some of these subjects. So I think we met maybe like years and years ago in passing. And
we met at one of the wellness conferences.
Okay.
I think it was the first or second one, maybe the second one. We met there.
Yeah, I was wondering.
Yeah.
And for a long time, your name flies around in my practice, and people talk about you and the work you're doing. And I think there's so much overlap. And anyway, I just have wanted to connect for a long time. So I'm looking forward to this conversation.
Great.
Yeah. So I think what I'd like to do first is just kind of talk about your journey as a psychologist and now a somatic experiencing practitioner.
Right.
What did your practice look like prior to somatic intervention? What wasn't working, and what kind of I know it's a loaded question, but what led you to involving that in your practice now?
So I was trained as a psychologist a long time ago. I graduated, I think, in 1997. And the focus of my training was pretty much exclusively on mental health dysfunction. So the symptoms and what their diagnoses are, and what the evidence-based treatments are for particular diagnoses. And the interventions pretty much consisted of cognitive behavioral therapy, or, family therapy, which was often involved. And I did a lot of family therapy in my history, but addressing thoughts, feelings, and behaviors was the primary focus of intervention. And talk therapy was thought to be the way to do that. And I started working at McCambridge Center, which is a treatment center for women, state funded for the most part. That was my first therapy job. And I stayed there for much longer than I thought I would. I was there for 15 years because I loved it. And during that time, I started out as a therapist, and then I became the clinical supervisor and eventually the clinical director. And in that process, the idea of trauma, and trauma being the underlying mechanism, especially for women, in why they develop addiction, started to become part of our conversation. And so,
what year do you think that was when that started?
That probably would have been, 90s. So I started working there when Nicole was 2. So that was 1990. So I would say that was probably 98, 99, 2000. That's just a rough guess, but in the middle of my time there. And so one of the things we developed was what we called at that time a dual disorders group, where we talked about mental health and substance abuse and how the two things were related. And then we also developed a trauma group where we started talking about how trauma might manifest itself in addiction symptoms, and how addiction was a not necessarily a choice disorder, but much more of a, you have symptoms that are overwhelming your body, and anyone would want to run away from those symptoms if they had them.
It's so painful inside that they're
right. And so people find different ways. People find different ways of running away from that or not feeling that. And for you, it was drugs and alcohol. And I remember one of the things that we would talk about in staff meetings was how exciting it was to see women who had maybe were in treatment because they'd lost custody of their children, and how they would feel the relief when we would say, this is not a choice that you're making. You are doing this because it feels so painful to be living in this body that was sexually traumatized from the time you were 4 on, and drugs are the way to feel normal.
Yeah.
And just the relief at not feeling that responsibility was really, really big.
I can imagine.
Yeah. Yeah. And so talking about it was great, but I also felt really limited in treating it. So EMDR was just starting. EMDR is eye movement desensitization and reprocessing. It was just starting at the VA when I was at the VA for my internship. And which would have been in 96, I think.
And were people open to it at the time? I feel like, yeah.
I wasn't open to it. No, yeah. I thought this is voodoo.
Right.
I don't understand how this works. There was a psychologist at the VA that was doing it. And I was like, what are they doing? That is just, and here we are, however many years later, and lots of people are trained in EMDR. It's the evidence, it's the treatment of choice for trauma. But it was the very beginning of going around words and having an impact on the brain and the physiology of the person without necessarily using words. And so with EMDR, they use some sort of bilateral brain stimulation, whether it's tapping on alternate legs, whether it's moving the eyes. There's a couple of different ways to do that. And I'm not trained in EMDR, so I don't know much about it other than that. But that was kind of the beginning of incorporating the body. And then I quit working at my Cambridge Center. I was teaching at Stevens and started a private practice, and it was really small. And I really like teaching. And so I just started hiring people, either supervising them and then hiring them after they were done with their master's or whatever. And, kind of ended up with this practice that had 5 or 10 people in it. Moved a couple of times because we grew bigger. And I was always dissatisfied with treatment of trauma because I can create a great relationship. I can work with a client from a kind of inner child perspective where we're trying to heal some of the wounds that the child experienced. But I never really felt like it made much difference in the long term in terms of flashbacks and nightmares, and usually had to resort to medication to kind of dampen those. And so I went to a very brief introduction to somatic experiencing that someone here did. And I thought, well, I'll try it. It's a long training. I'll go to the first 4-day training. It was in Golden, Colorado. If I don't like it, I don't have to finish it.
Yeah.
Right. And first of all, the first day I was like, oh, these are my people. Like the people there were excited about incorporating the body. There were as many massage therapists there as there were mental health practitioners. And there were some OTs. And so there's this kind of mix of people, some who worked with the body, some who didn't. And by the end of my first day, I was like, okay, this is why what I'm doing isn't working, because it doesn't incorporate what is trapped in the body in terms of energy. And so like the short way of describing it from that first day is when you're in a situation where you're trapped and you can't fight or flee, that energy stays stuck in your system until you can finish that protective response. Our body is automatically going to want to fight or flee when we're under danger. And if we can't, that energy stays stuck until we can actually finish that, whether it's in image or in real time or in storytelling. With kids, they do it through play therapy.
Mm-hmm.
So kids get better when you do trauma treatment because they're acting it all out and they're putting the perpetrator in jail and saying, you can't come out. And so they're expressing that fight response in lots of different ways and they get better. But adults sit there now with their hands clasped talking and there's no movement and they've learned to kind of contain all of that.
Contain. Yeah.
Right. Exactly.
Yeah. And the children haven't been containing for so long.
No,
so it's you give them that opening and they're like, oh, and it just goes.
Well, and play is their language. And so it's automatic when you interact with a child, you say, let's play. And, a kiddo will reenact, because that's part of what happens when you have trauma is you reenact a situation over and over, looking for some solution, some ending that ends in a way that you're safe. And they automatically do that because they don't have that kind of top-down thinking. They just go with their body, what they want to do, and they're kind of drawn to that. And I've been doing play therapy for a long time, but I knew that those kids got better, but the adults weren't.
Okay. Yeah. So you saw a lot of adults that you were doing all the things that you were trained to do, and you were establishing these very trusting, warm relationships, but it just felt like it wasn't going anywhere. So going back
with their trauma symptoms,
right? Which is why they probably need the therapy the most anyway, right? Because it's disruptive to life to have flashbacks and panic attacks and PTSD symptoms.
Right. Yeah.
I could see how that would be so disheartening.
Yeah. And the other thing that I was really attracted to with somatic experiencing is it was very gentle. So with EMDR, you tell the story. You do lots of prep work and lots of what they call resourcing, but you tell the story. And for some people, it's really overwhelming to tell the story. Yeah. And I think, practitioners are getting better at chunking it and breaking it up into smaller and smaller pieces. I think that's one thing they've learned to do. But it can be really, really overwhelming. And in somatic work, you don't have to tell the story. You don't necessarily have to talk about what happened at all. And it just felt really gentle to me, which is much more my style. So that was really attractive as well.
What was your first experience? I'm imagining that at this training, they probably have you doing the work at the same time.
Absolutely.
So what was your first experience of doing it and then feeling like, oh, wow, this really does feel different? Are you comfortable talking about it? It might be pretty personal.
I mean, there are so many because this is a 3-year training. Yeah. So it's intense. It's, what is it? 6 4-day modules and then 2 6-day modules spread out over 3 years. And during that whole time, you're practicing every single day in triads. And then you have to get 12 personal sessions with somebody who's a trained somatic experiencing practitioner. So I got lots of treatment. And it sort of collided with my new awareness that I had trauma, which I didn't know until I was in my 40s.
Wow.
And I got my first divorce and something shifted in my family of origin. And I started saying, why is this way? And my sister told me one little piece of information and I immediately had a flashback to something. Okay. And it took about 10 days to kind of get some distance from that. But I was like, oh, okay. And things started to click. And so that was around the time I started the SE training. So it really worked very well because I got lots of opportunity to work through that. So one example is at the beginning, a lot of what we did is simply learn how to read our own sensations, learn how to notice our own internal sensations and follow them. And the provider is there to help you not get overwhelmed, essentially. And so if you're starting to notice, like if you might say, well, give a thought to something that was slightly stressful that you went through in the last month. And oftentimes those slightly stressful things are way more stressful than you ever thought they were if you take the time to pay attention to the sensations. And so the provider's there to help not get overwhelmed, because the whole goal of SE work is to not overwhelm the person. And so there was one session where I was doing that, and I felt this image sensation in the middle of my back that felt like a target. And I can't describe, I mean, it's weird to say, because at the beginning, the first time somebody said, well, just take a minute to check in and notice what it is that is happening internally in terms of sensations. And sensations are things that are color. They're like underlying emotions. This is what leads to an emotion. So I use the example of butterflies in your stomach. Butterflies in your stomach is a sensation that we label as anxiety. There's always a sensation underneath the feeling word. So the first time somebody asked me to do that, I'm like, what are you talking about? I have no sensations. There's nothing. I don't know what you're talking about. And you just practice and practice and practice. So I felt this target on my back, and it took my breath away.
You feel it, and then visually you got a mental image of it.
Well, yeah, I just got I felt it, and what it felt like was a target. And it took my breath away. And so as a practitioner, it just helped me to just feel that. And if it started to take my breath away even more, she would say, can you find the edge of it? Can you just go to the very edge? And I could do that. And then I could take a little bit more of a breath, because that gave me some distance from it. And the thing is your body wants to heal this stuff. And so if you give it the room, it will dissipate that sensation. It will take care of it. And so as I just had some distance from it, and we use touch in SE. And so the provider said, can I just provide you with a little bit of touch on the shoulder? I said, yes. And she did that, and it helped immensely. And then that feeling of a target just got less and less and less. And I could feel tingling in my hands and my feet. And tingling is always some kind of discharge of adrenaline, essentially. And so that's an example. We spend a lot of time, what we call resourcing, like in EMDR, where we practice with people taking in pleasant sensations first. So that kind of thing happened maybe in, so the first 4 days, so maybe day 5 or 6, kind of in the second module, because we'd spent a lot of time in the first just working with pleasant sensations. When people have trauma, they are cut off, and they're cut off from what's hard, but they're also cut off from what's good.
Yeah.
And so teaching them to let pleasant sensations sink in is part of the work, a big part of the work at the beginning, because it provides some balance.
I do notice sometimes, I'm trying to think of how to say this, but I think now that I understand this so much more, I think that is one of the conversations that comes in really early when I'm talking to somebody is that conversation of, I know you don't feel like you have trauma, because I'm not dealing with the people that have had, trauma all through their childhood. That's not what I work with. I'm dealing with the people, like you said, that are like, I had a great childhood, everything was fine. My parents were loving, And so it's a different kind of conversation. And we have to hunt for it a little bit more.
Yes.
But that is one of the things that I like to talk about right away is that, where this has been contained, you're also that blocking the good feelings too, and so maybe you could speak to that just a little bit more.
Yeah. So I'll give a good example. So one of the early things that we do is we teach orienting. So orienting is basically using your eyes and to some extent your ears to take in your environment. So if you think about a deer who's in a meadow and they hear a twig snap, they'll look up and they look around, and you'll see their ears twitching too, because they're listening. So they look around. That's orienting. Is my environment safe? And if they don't see any danger, then they go back to eating in the meadow. So as humans, we don't do that, but we're mammals. We're supposed to do that. And if you have trauma, we can become more and more and more constricted. So, but even people who don't have trauma do this, right? They read, they look at their phone, they do things like this, and they're not aware of their environment. Mm-hmm. So we teach how to orient, which is using your eyes to take in your space. And sometimes I'll tell people, can you find all the diagonal lines in the room? And you'll see them take a deep breath when they do that, which is their system just settled a tiny bit. And then I'll say, so find something that's pleasant in the room and just let your eyes kind of take it in and describe to me what that feels like internally. So we just do a lot of that. I teach about preferences. So I'll have clients pretty early in my work with them, because this is a good way to teach about sensations. I'll say, okay, that pillow right there. So just notice that it's just right next to you. And then I'll say, take it on your lap. You just take the pillow on your lap and you can wrap your arms around it, or you can just leave it sitting on your lap. Just take a minute to just notice what that feels like. And then put it to the side. So we do that for like 20 or 30 seconds and then put it to the side. And I'll say, which do you prefer? The pillow on your lap or not on your lap? And I'd say 95% of people have a preference. And usually it's to have it on their lap. And then I'll say, how do you know that that's what you prefer? Pull it back on your lap and notice what happens. And then they can see the difference. Mm-hmm. It's easier to find sensations if you have a difference. And they'll say, oh, well, when it's on my lap, I feel just a little more like I can settle. You know, I feel a little bit more grounded. And I might say, take it off and notice what happens. And they're like, oh yeah, I feel a little bit more tense in my, so it's teaching that so that you can start paying attention. So I'll tell them, you know, when you're out and about, if you go to a coffee shop, sit one place and then go sit somewhere else and see which one you prefer, and then stay there and let that preference sink in. Why do you prefer it? What happens in your body when you do that? So it's teaching lots and lots and lots of tools like that to take in the positive stuff. When you go to bed at night, you know, really sink into the bed and really feel the covers pull up over you and notice what happens in your body and with your breathing. And so that's doing two things. It's teaching them to notice sensations, and it's letting that positive sensation sink in a little bit more.
It's so simple, but it's so powerful.
It's very,
and I'm wondering how many people that are they learned through their stress management, trauma response to be the people pleaser, or to be the one that's like always very laid back. And if it helps them just with simply giving themselves permission to have a preference again.
Yeah.
You know, I was definitely that person for for my whole life. I was like, oh, I'm fine. I'm good. Whatever you want. I'm good. Like I just completely trained myself out of having a preference of anything.
Right.
And now I have such strong preferences. Now that I'm tuned in.
Right. And teaching people to say, what do I need right now? You know, and I tell them that the things to think about first, do I need a drink? Do I need some food? Or do I need to lay prone for a while? Or maybe go outside from the room that I'm in, because they're not used. And then if you know that you need that, go do that. And then what does that do for your body? Yeah. I mean, it's definitely kind of overlaps with codependency, and especially for women. For women, it overlaps with codependency. For men, it overlaps with a different kind of codependency where it's like they don't have any needs, or they force their needs onto other people or whatever. Yeah.
Yeah, that makes sense. So from your perspective, do you feel like somatic interventions, just kind of across the board, do you feel like it's necessary for trauma healing? I know that's a blanket statement, but
so, you know, I would call EMDR a kind of a somatic intervention. And if you include EMDR,
I definitely would. Yeah.
Yeah. I would, I mean, it's so individualized. And I think that you can heal without it, but it's only to a certain level. And then and you may not even know what's missing. You may get better. You may get better with talk therapy. You know, I can't overestimate how much it helps people just to say what you went through was traumatic. And this is how it affected you. And this is why. And the context that you were in was really unhealthy for you. Sometimes that's enough to empower people if they, depending on what they're experiencing. But somatic interventions can be applied to all kinds of healing. And so we're seeing lots of people who have massive stress post-pandemic, and teaching them about their nervous system and why their nervous system is out of whack and how that actually causes mental health symptoms, that it's not necessarily a disorder. It's an adaptation that your nervous system has made to a disordered environment.
Yeah.
And so I talk a lot about depathologizing mental health, that mental health symptoms are oftentimes just an adaptation to a context that is unhealthy, whether it be work, whether it be political environment, whether it be a school system or a family. And in some ways it's just the air we breathe now. I'll talk about, to parents whose kids are resistant to going to school now after the pandemic. And I'll say, okay, listen, they were 4 and 5 when that was happening. And all they heard was 2 things that are fundamental to survival were unsafe: the air we breathe and other people.
Yeah.
And they can't turn off that vigilance that we created for them and that they adopted by saying, no, it's safe. You can go back to school. There's other things that we need to do to help their nervous system to feel safe. Because once they're kind of indoctrinated in that the world is unsafe, it doesn't just turn itself off.
Right.
So I would call them somatic interventions, but we've been doing a lot of education about the nervous system, and a lot of the programs and work that we do, because that explains so much. This is why you're anxious, right?
Yes. You're not broken.
Right.
You're not broken. You feel broken and it feels so uncomfortable, but that adaptation worked. And I think we could celebrate that too. Got a lot of people through some really tough times, but I love the way you're describing that.
There's a couple of little tiny books that we give to clients to read that really helps get them kind of on board. One is called Trauma is Really Strange, and the other one is called Anxiety is Really Strange. They're by Stephen Haynes, Hanes, or Haynes. And they're little kind of graphic novels, are $10. They're very helpful in helping people to understand that kind of depathologized, your nervous system is adapting. This is why you feel this way. And then it kind of starts the process of what's needed to kind of unwind that. He also has a book called Pain is Really Strange and Touch is Really Strange, which are both kind of adjuncts that we don't use as often, but they're also really, really good.
Oh, I love that.
They're awesome.
So how are you guys doing this education right now? Do you have online programs to send people to?
Right now, the majority of the way in which we're doing it is individually with clients.
Okay.
Honestly, the reason for that is because we're so swamped with clients, we can't even breathe. I would love to create some kind of online stuff. I would love to do live groups where we teach about this stuff, but we're so swamped with individual clients, and people are less willing to come to in-person groups than they were before the pandemic, which would be my preference, is to do it in person. But there's all kinds of stuff out there on the internet that people can find, that, I can give you some names after this of places to look for that. But primarily it's one-on-one with people that come with us, and my teaching it to my staff. So I supervise interns and I supervise provisionally licensed individuals. And so there's a lot of what I'm knowing. I came back from my somatic experiencing training as the only SEP in Columbia. There's now 2 others, I think. But I had so many referrals. I thought I have to operationalize this in a way that other people can use it, because I can't treat everybody. And I want my people to have some of these skills. So there's been a lot of training and exposing them to certain books and trainings, and then practice with each other. And so that, and in my nonprofit HeartSpace clinic, one of the interventions that we're doing is called the Safe and Sound Protocol, and it's all based on all of this stuff. And so we're doing a lot of education with people who are involved in that program. Either their children are involved in it or they're involved in it as an adult. And that's all grounded in the nervous system work and polyvagal theory and all of that And then the other thing that we've been doing is when the pandemic started, I thought, okay, there's 3 groups of people who are going to be really affected by this because they're helping people who are being affected by the pandemic, but they're also being affected by it at the same time. So mental health, medical workers, and teachers. And so for a year and a half, we got funding from the city, and we did one-on-one sessions and group sessions with those individuals where we taught some of this stuff. We taught, why is it that I can't sleep? And we taught a lot of what we call nervous system regulation tools, called NSRs. And they're just little teeny tiny tricks that we teach people. We did that for a long time, multiple times a day. And the group that attended the most were people from the schools. They loved it.
Yeah.
And so then we continued, and we just finished another round mid-December, and they're just 15-minute Zoom meetings 4 or 5 times a week where people come in and we just teach them a little tiny settling exercise. And people tend to find like the ones they like the best. And then, and just the feedback that we got has really been phenomenal. And then for that year and a half, we gave free sessions to anybody from those professions. And then in the last year, we've just kind of focused in on teachers because they're really, really stressed out.
Yeah, they're struggling.
Really struggling very badly. And so we've been doing free sessions or reduced fee sessions. The first 3 are free. And then based on their income, they might have a copay after that.
Wow.
But we've been doing that we did 242 sessions this year.
Wow.
And we're trying to fundraise so we can continue to do it next year.
That's amazing. I mean, I'm like, when you sent me all the things that you're working on, I was like, oh my gosh, woman. I mean, you're just doing so much for this community, and it just, it brings tears to my eyes, but the teachers are struggling. They are. And, I mean, you could see why it's not hard to see. So I want to rewind just a little bit. Talk to me a little bit more about the Safe and Sound protocol. Is that a series of, are they sessions with you? Just tell me a little bit more about that.
Yeah. So when I was in my SE training about midway through, one of my teachers was talking about Stephen Porges, he is a neuroscientist who developed the polyvagal theory. But he had been studying how to help kids with autism because he believed that their difficulty in relating socially was because of their auditory and sensory sensitivity. And what he knew from studying the nervous system is that if you don't feel safe, you can't be social. You can only do social 100%. If you feel safe. And he focused in on one of the ways that the nervous system accommodates when somebody doesn't feel safe. And safe is there's too much going on, too much, too fast, too soon, which is what kids with autism and adults with autism experience sensory wise. Too much, they'll cover their ears. And so what he found is that when that happens, the nervous system feels unsafe, thinks the world is unsafe. So our hearing, which is supposed to pay attention to human voice the most. So when you talk about range of sound, high frequency is like shrieking, and that the nervous system responds to that as terror. Low frequency is growling, and the nervous system responds to that as fear. And mid-range is voice. And so over time, our ears are supposed to screen out low frequency sounds and screen in voice. But if the nervous system doesn't feel safe, it doesn't do that. It starts to listen for low frequency sounds more and more because it's hypervigilant, right? If the world isn't safe, I need to be vigilant and listen for lack of safety. And the nervous system doesn't listen for safety. It listens for lack of safety because it's going to err on the side of caution, right? So if you get 2 pieces of information, like somebody's growling at you, but they're smiling, your system's going to respond to the growl, not the smile. That's why inconsistency in facial expressions is such a big deal.
Yeah.
Anyway, so he developed an intervention for the ears. It's a listening intervention. It's music that is, I don't know how they do it, but they tweak it so that the high frequency and low frequency sounds are gone. And all you get is the mid frequency sounds. And so there's no sounds of danger whatsoever. There's certain songs. A good example, I remember when I went to a conference about this, Doris Day's Que Sera Sera.
Okay.
That song is kind of the epitome of that's a song that communicates safety because it's all in a certain range. But classical music and Disney music are good examples. And so they take those songs and amp them up by taking out that mid-range, the high and low frequency. And so it's 5 hours. The first 2 days kind of titrate. So it kind of exposes you to a little bit of it and a little bit of it. And then day 3 is a little more intense. And then it kind of winds down. And it does 2 things. It sends sounds of safety into your nervous system through all that music. And it recalibrates the middle ear so that it takes in sounds more appropriately.
Interesting. That's
so we've been doing that for 4.5 years. I shout out to the Boone County Children's Services Fund, which is funded by our mental health taxes because they fund us. And we just got refunded for another 3 years. And we do pre and post testing. So we measure anxiety, depression, and trauma symptoms pre and then post and then 3 months post. And it's really amazing how this can affect kids in particular, but also adults. And the reason why it's different is because adults have layer upon layer of trauma.
Yes.
So we have to be much more careful with them. When you have been on alert for so long, sometimes safety actually feels threatening. Because when you start to relax, then your nervous system is like, I'm going to go right back. So with adults, we have to take it really, 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 really slow and careful. And we do a lot of teaching of regulation skills when they get activated. But we can slow it way, 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 way down. But for kids, because they don't have all those layers, we can do it a little bit faster and we see the effects much, much sooner. So
you were saying 50 to 80% of your clients had decreases in anxiety, depression, and trauma symptoms. I mean, that's so exciting.
Yeah, it's really, and the anecdotal, like we will ask for, just tell us, how we send out satisfaction questionnaires. And parents say things like, this has changed our life. And I had one parent who said, I want to cry when I write this to you because this has changed our life. And it'll cause kids to do this 180 where they're, they can't go to bed at night or they lose it when there's any kind of change. And that's just because their nervous system is too activated. And all we're doing is just bringing down its baseline so that those things don't send them outside of their window of tolerance. And we do a ton of teaching to parents about this. This is why we're doing it. This is why we think it works. This is how to look for things that change. These are the signs that this is too much, because sometimes there will be some symptoms of it's too much and we need to take a couple days off. We do it all over telehealth. So it's a digital thing that they can download to their iPad or iPhone. And then our staff is with them when they're doing the listening.
Okay. So they do come and sit with you all, or with someone while they're going, listening to the audio. Yes. Are the sessions, is there a talk processing part of it too? Or it's just you come in and listen?
Sure. No. We're always checking in. What are you noticing? We'll say, if you notice anything odd, just anything odd, please let me know. So sometimes they'll say, I don't think this is related, but my jaw feels kind of tight. Yep, it's related. Let's help that jaw. So we'll help the jaw and then we'll talk about why that might be happening.
Yeah.
And we'll talk about, okay, so what we probably need to do is just take a break. We were going to listen to 30 minutes, but we're just going to stop here because it just amped your nervous system up a tiny bit. You got a little constriction here and we want your nervous system to just settle. Right. We never, ever, ever, ever push. Most people want to push.
Yeah.
Right. I want to just get through this and get to the other side of it. And a lot of what we're teaching is that's going to just re-traumatize your system. Right. That's not going to be helpful.
Yeah.
So, but we're sitting there with them the whole time because there's a lot of education and intervention that we do. so that it's not too much.
Sure. Okay. I was just trying to get an idea of what that looked like. So I understand that you just went through a training for prenatal and birth trauma. And I would just love for you to talk about what you're doing with that. I mean, of course, I started learning about all this stuff after my nursing career, or kind of at the end of it, and of course I look back and think, wow, I mean, I was a very good nurse and I had such amazing bedside manner. So I think I did a lot of things right, but in hindsight, there's a lot of things that could have been better. Let me just put it that way.
Well, and what I will say is a part of the intervention is finding those bright spots. So I'll spend a lot of time talking with couples about who were the nurses that were especially helpful, because that is part of resourcing. That's like, oh, this was a really hard event, but let's talk about the people that were right there who made eye contact with you. So you would probably be some of those people's resources, right? Yeah. So this came about because when we do the SSP with kids, we do a really extensive intake because we're looking for things that might mean that it's not an appropriate intervention. So for example, if the family is living in a dangerous home environment, we don't do it because they need a hypervigilant nervous system because it's not safe. Yeah. So we're looking for all of that.
Is the SSP, is that the intake for the somatic?
The safe and sound, safe and sound protocol.
Okay.
Yeah. So it came out of the safe and sound protocol. So we do that intake. And what we started to find is that almost every single kid had birth trauma. So these are 5, 6, 7, 8-year-olds who have all of these symptoms of anxiety and overwhelm, and there's no other reason why. They don't come domestic violence situation, families are stressed, but not highly, they haven't been homeless. It's like, but my kid just can't handle this or that or this or that. Yeah. And then one of the questions we ask is, tell me his birth story. Oh, it was awful. Every time.
Wow.
And I'm like, okay, there's something to this. And so I started doing some reading, and I found Kate White, who is a craniosacral therapist and an SEP on the East Coast. And she trained with Ray Castillo, 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 who's now deceased. And she was doing interventions for moms and babies or kids who'd had trauma. And she had this she's amazing because she has so many things that she makes available for free to the public because she wants people to be working with this, to be seeing this, to prevent it if possible. But at the point where I'm at and the people that I work with, it's about, reacting to it, but educating. And, there's 3 pieces that we do. One is create that resource. So we go through every single stage of preconception, conception, pregnancy, birth, and after, and identify all of the positives, all of the support, every single thing. And usually it's a much bigger map than they would have ever expected. And then we do trauma intervention with the mom and the dad about the birth. And that's basically from somatic experiencing. We work with a single event, and we start at the end with when do you remember seeing your baby for the first time afterwards? And what did you feel? And oftentimes they'll feel in that moment what they felt then. Which side was the baby? And we try to really, and then we talk about the hard thing a little tiny bit. And then we go back to, okay, remember what it felt like. So we do that kind of work until we kind of help discharge some of that energy. And then this is my favorite part. And I just did this last week. We bring the kid in and we tell them their story. So the parents say, I want to tell you about the day that you were born because it was amazing and it was hard. And the whole idea is that if the mom is terrified, which at some point she usually is, the baby thinks it's going to die. It's terrified. Everything that the mom feels, the baby feels, but without a nervous system or a brain.
Right.
And so we tell the story from the perspective of, and that was really hard for you. I think you were scared and terrified and you didn't know if everything was going to be okay. And I'm so sorry it was like that. You didn't do anything wrong. So we tell that story, and then we ask the child, do you want to redo it? Do you want to redo that birth story? And so I just did it with the little boy last week and his sister. And we have a tunnel. And then we have, I call it a squeezer. It's the thing that you use with kids who have sensory issues who really like pressure, and they push themselves through it. And there's a roller at the top and a roller at the body. And it's kind of like a roller for a pie crust or something. It just kind of gives them this pressure. And so that's at the end. And so crawl through and push through, and mom's right there, and they're talking to him, and he comes out and he like lands in her lap, and he goes,
oh,
like a total baby cry. And she's holding him. And he's like, I want to do it again. So he does it like 4 times. And then he says, I want to take all my clothes off and do it just like I did it then. So we didn't do that in the session. She said, you know what? Let's do it at home.
Yeah.
We've got a tunnel at home. We'll do that at home. And so I kind of prepped them for, he may want to do this 200 times.
Yeah.
And that's his way of getting mastery over it. But you redo it for him and for the parents. And it's just like play therapy. When you reenact something with a different outcome, the nervous system doesn't know that it's not really happening.
Right.
It experiences that, oh, finally.
Yeah.
Finally, everybody's present. Mom's not knocked out from, being under anesthesia. Dad's right here and not terrified, and I can land in your lap and everything is okay. And the rate of C-sections is crazy.
So high.
And that pressure from that squeezer, I think, is really beneficial for the kiddo, because they need to go through the birth canal. And that's something that just kind of sets everything in motion, physiologically and physically. And so I love having that squeezer thing, because it's just like, this is just like it. You would squeeze right through it and he would come out. Yeah. So that's
interesting.
That's the first family that I've done it with, like all the way through the whole process. But that's what I want to start doing, is more of that.
I was just thinking too, I mean, how many of those kids that had birth trauma just always had anxiety and had no idea why. Yep. And then, and they're in the safe family, and they're in the idyllic life, and they always have anxiety, and they always feel broken and have no idea why, and I'm thinking, I just had a conversation with some girlfriends the other day, and we were talking about how, just because things look idyllic doesn't mean that there's not trauma in the background. And I'm just wondering how many of those poor kids end up with addictions, because the outside world looks at them and they're like, oh, you should be fine. You should be fine. And it just started with a really horrific birth, or, maybe trauma in the womb, and it all just got, imprinted on their little systems. And
exactly. That's what I tell parents, that their nervous system is not developed. So that fear is imprinted in their nervous system, and then they're born with it. And until we can help them reenact that in a non-fearful way and acknowledge what they went through and how scary it was and redo it different, their nervous system is just, the world isn't safe.
Right.
The world isn't safe. That's what it feels constantly. And the relief for parents too, because many times they'll say, well, I thought that was really awful, but nobody said anything to me about it. So I thought that's just the way it is.
Yeah.
Like, no, that was horrible, right? You didn't want that to happen, and you had to be strapped down and have a C-section. That is traumatic.
Right. And even a lot of times C-sections, I'm just flashing back to my nursing career, and even C-sections where it wasn't necessarily a crash stat horrific C-section can still be very emotionally traumatic.
Right. Yes.
And we haven't even really talked about this, but I'm just thinking back to something happening that you don't want, that you didn't ask for, and how that just kind of draws up all the trauma of that happening in the past. Yeah. And it's this so-called like normal experience, but it's not.
Right. Right. Yeah. And the evidence says that the rate of intervention after the first intervention in a pregnancy, so either Pitocin or whatever, then the rates of intervention just like quadruple, because it's a different trajectory, right? It's like you give someone Pitocin, and it's like, it's our agenda now that you come out. It's not the baby and the mom's body's agenda. And that just sets a different trajectory. And that's why, then multiple things, we're trying to help the birth, but then end up in a C-section. And, it doesn't have to be traumatic.
Mm-hmm.
There's a lot of things that could be done to make it not traumatic, but that means changing a whole system. And maybe someday I will take that on, but because there's all it would take is a kind word.
Yeah.
All it would take is the doctor looking that mom in the eye and saying, you're going to be okay.
Mm-hmm.
We have got this.
Yes.
But that doesn't happen.
Right. With a few of them, it does. There was a handful of them
yes.
that had amazing bedside manner. But not all of them.
Yeah. And they just don't know, right? They just think I'm just working on a body and trying to get that baby out. And it doesn't matter how I do it. I just want to get that baby out. But it does matter how you do it.
It does. Yeah. It does. And it was not until much, much later that I really started putting it all together with how much sexual trauma gets re-triggered in the birth process. Yes. Even if things go well, that trauma gets re-triggered.
Oh, totally. And if mom's not prepared for it, it feels like a violation.
Or if they don't remember, and then
if they
then they have all these big bodily, visceral, anxiety feelings, and they have no idea where it's coming from.
Right.
Yeah. It's a lot. But I love that you're incorporating that into your practice. So if I say a client is going to come to you, do they come mostly with, because you're kind of doing the psychology and the body-based stuff, does someone come and say, I have this issue, I want to try SE, or is it kind of like patient to patient? Or can somebody come the reason I'm asking is I have this weird hip thing that I've tried a million things for. So do you ever have people show up there I just think this might be some sort of weird trauma thing that, that I'd like to work out in that way?
So I am trained in touch work. So the very last module of SE is training us in touch. And I knew that I wasn't going to use touch until I got more training than just that last module. So I have trained with Kathy Kane and Stephen Terrell. And I'm actually in the process of rereading my notes from Kathy Kane. Kathy Kane's amazing. She's a very intuitive touch healer, and I'm not. I'm not trained as a massage therapist. What I have found is that I don't necessarily have that intuition to okay, let's work with your hip and see what we can find. So I kind of stay away from that. Now, I have a therapist who is under my supervision who just got trained in a particular modality to work with chronic pain. And so she might get a client who has chronic pain and work with her. And it's from a somatic cognitive perspective. What I prefer to do is work with people who are seeing another therapist. That's my preference now. Now, I have lots of clients that I started with, but for the most part, if somebody says, I want to come to see you because I want to do SE, I don't have openings just to take on a brand new person, because what they generally want is therapy and SE. And I want to just do the SE or the touch work. So my preference is a client who is seeing a talk therapist and it's clear that they have they would benefit from somatic work. And so I work as an adjunct.
Okay.
And so I'll either do SE work around, I'm just getting ready to work with a client and her therapist on a car accident that she went through when she was 5. And we'll do a couple of sessions, maybe 3. Her therapist is going to attend so she can see, but I'm working on that particular incident. Or it's someone who has lots of developmental trauma, and it's starting to show up in GI issues and physical pain and maybe autoimmune disorders. And so I use Stephen Terrell's work, which is specifically for developmental trauma. And it's more of a protocol with touch, where we support kidneys and brainstem. And we do this routine over and over and over and over. And essentially, the idea is the body will heal if it feels safe enough. And so we use touch over and over and over to create those safe enough conditions for some of that healing to happen. And it's pretty amazing how doing that as an adjunct is can really help people make some shifts in their talk therapy that they hadn't been able to make with just talk therapy.
Yeah. I'm certainly not a therapist, but I do have people tell me And I, you know, with my colleagues that I know that do EMDR and all kinds of other things, it's like that same phrase comes over and over and over again. It's like, I've told this story, but I didn't feel better.
Yeah.
Until this with the somatic intervention, whatever it is, you know,
right.
It's just so powerful. And
now
really that
is.
I know about this stuff, and I'm sure you can agree with this, like, I feel like we could remove 80% of the curriculum in our education system.
Oh, totally.
And let's just teach our kids how to take care of their nervous systems and how to help them help regulate and orient and resource. And
well, we start, but we start with the teachers.
Yeah.
That's why we're focusing on the teachers.
Yeah.
There's tons of interventions for kids. But if we're not helping the teachers, then we're not helping the kids. Because if the teacher is dysregulated, every single kid in that classroom is going to be dysregulated.
I am so glad.
That's why we're focused. Yeah. That's why we're focusing on the teachers, because they don't get the help and support. And they set the tone for, you know, their nervous system sets the tone for the entire classroom.
Yeah.
And so if they don't have those tools to down-regulate in the morning, as the day goes on, then everybody's going to be out of their window of tolerance, for lack of a better term, in their classroom. So that's why we're focusing on the teachers.
And what are your thoughts on that? Because I completely agree. And I think partially it is that when we see somebody that's dysregulated, whether it's a caregiver, a teacher, a nurse, you know, whoever the leader is, right? The so-called leader of the group. I think there's a lot of visual cues, but I personally think that it's an energetic thing too. And which is why people can't fake it, right? Like they can put on the smile and they can, you know, they can talk in the tone, but it's, if their energy isn't really regulated, the kids feel it. Right. And I think
it's nervous system to nervous system. So if you ever heard of like a dog whose owner gets upset and the dog comes and sits by you, it's because their nervous system is reading your nervous system and knows you need something.
Right.
And so it's, you know, and so nervous system or energy, it's the same language. It's the same word.
And the nervous system is running on energy.
Right. And so, yes, everybody's nervous system is like, vibrating if the person who's, who wants and needs to be available for those kids isn't even able to be available for themselves. So it's about helping them to be present for themselves and be able to settle themselves. And then they can take a deep breath and come to the child. And it's not just coming to the child like, what do you want? But it's like, what can I do for you?
Right.
And so those, you know, those nervous system resets that we do teach people how to do that.
Yes.
Right. Like, how do you do that in the moment? And we really teach them how to pay attention to, okay, what do you notice when you do that? So can I do a little practice with you?
Oh my gosh, absolutely. I'd love that.
Yeah. I want to teach you a little thing that, and you may already know it, but
well, let me ask before we do this, because I definitely want to do this, but I keep forgetting to ask. So I have come across like SE videos. What are your thoughts on who could try this on their own via a video and who should not?
Well, I would say everyone should not, because you don't know what's underneath.
Right. Okay.
You don't know what's underneath. There's Irene Lyon, Lyon, has a fairly robust online program that people do. That's she's an SEP, and she's kind of made her way by making this accessible to people online for a fee. If you want to do it and you don't have access to an SE practitioner, I would look up her. You don't want to do it because the whole point of it is trauma. We don't know what we don't know. Trauma happens in isolation. So things are traumatic because there's no nurse there to say it's going to be okay. And so you're alone. So healing it shouldn't be alone because it happened alone. So it's got to be in the context of a relationship. And even if that's somebody that's teaching 5 people to regulate their nervous system in a group, it's got to be in the context of a relationship. Otherwise, it's just re-triggering and it's not breaking that association between my trauma and I have to be alone in order to deal with it.
Well, that was going to be my next question, is if there's any kind of, the reason I'm asking is because from my perspective, it feels like with after the pandemic, all the kids, all the adults, all the elderly, I don't know what the statistics, I tried to look it up the other day to see if there's any statistics out there as far as like the percentage of anxiety.
It's early to get those, but we'll have those probably in a couple of years where it's like, it's skyrocketed.
It feels to me, and I have talked to a lot of clients and family members that say, like, I've tried to get into the therapist and I can't, and there's this kind of looming, really pressing issue with people running around with anxiety, and they can't even, they never needed a therapist before. They didn't think so. And then now they need help. And so I think a lot of practitioners, a lot of people are turning to these like kind of online group things because they're desperate. So that was why I'm asking.
as long as it's a group and it's being run live, and it's being run by somebody who has the training, then I would say go for it. And that, Irene's one is just one that I know of, but accessibility is really, really important.
Yeah.
And so if it's, as long as it's run by somebody who's trained, and you have the presence of somebody to support you, then yes, groups can be really effective.
Yeah. And I mean, that was one of the things that I wondered about too. I'm just having things kind of flash in my mind as if like, if in a group like that, you actually do have a partner, a sibling, somebody that you can say, hey, I'm doing this. Can you play this role for me?
Yes. Yeah.
And how helpful that would be.
Yeah. Yeah. If you did it together, right? If you're a sibling, then you might have some similar issues. Then certainly, if you ever saw something that you thought, I wonder if this would be helpful for people, you can just send it to me and I'll kind of vet it.
Okay.
And say, here's the reasons why I think it would be good. And here's the reasons why I don't think it would be good.
Right. Yeah. Well, and I think just to kind of, for our listeners, trauma is deeply stored in the body, in the nervous system, right? And so as you start to use these techniques that really start to unlock the energy, you can unleash a trauma that you had no idea was there and be very dysregulated and become emotionally flooded, and have full-on flashbacks. If there's something in there. And I think I'm speaking, a lot of people know they have trauma. And so they'll go, ooh, I'm not going to do that on my own. But I am really speaking to the people that are like, my childhood was great and everything was fine. And so they might tiptoe into it. But when you start to do this kind of work and let that stuff kind of breathe, things can come up and it can be very dysregulating and scary.
It can be overwhelming. And, a good example would be, well, I mean, first of all, most people will describe something to me that they don't realize was overwhelming for them, right? Because they put it away. But even just like a baby born with lack of oxygen, like that's stored somewhere and that can come out. There are different programs that teach the breathing techniques for nervous system regulation. And sometimes that can even tap into some of that.
Yes.
And so just, being careful. But if you find things that are just about teaching you to be a little more regulated, that's not going to do any harm ever, because most of us are overactivated as opposed to underactivated. Underactivated happens when fight and flight don't work and you shut down and freeze. And most of us are up here most of the time. And so just learning to regulate a little bit is going to be helpful.
Yeah. Okay. Well, I'm ready now. If you want to take me through it.
And one thing I wanted to just say about the Safe and Sound protocol, if there are listeners from Boone County, we have money to provide that for free to children and to parents of minors who live in Boone County.
Fantastic.
So if it's HeartSpace Clinic, Como at gmail.com.
Okay.
If people are interested in that, HeartSpace Clinic, Como at gmail.com.
Awesome.
And our website is heartspaceclinic.org.
Okay. I'll put that in the show notes for people. I mean, you've got a lot going on to help this community. It's really exciting.
Yeah. All right. So let's just do a little regulation exercise.
Sounds good.
So just take a minute and feel your feet on the floor. And if you're sitting in a chair, just imagine that the chair kind of comes up to meet you. just to provide a little bit more support. Just let it rise up to meet your bottom. And then just notice where your tongue is. If it's on the roof of your mouth, just let it drop. So you're just kind of imagining your tongue just dropping to the bottom of your mouth, almost like it's melting. And then we're just going to raise your tongue up to the roof of your mouth again. Notice what happens. Drop your tongue again. This time, be really curious about what happens when you drop it. Notice if your shoulders move. Notice if your breath changes. Let's try that again. Tongue to the roof of your mouth. And let it drop. Notice if there's any shift in your hips. Notice if you feel any sort of dropping sensation. If you can find some kind of sensation like that, just follow it. Just watch what happens. Notice your arms get a little heavy. If there's any sense of movement downward, I want you to just follow it with your attention. Super, super curious about it. And we're going to do something called vooing. So vooing is making a foghorn sound, and I'll demonstrate it. So it goes like this. You take a breath in, and then you voo all the way out until you can't.
Right when you made the sound,
it
did it. Like the whole time I was like, that's so funny. It went completely
that's
silent.
Hilarious. Okay, let me try it again.
Okay.
So that's the sound.
Okay.
And breathe out all the way until there's no more air. And then you take another breath, and we do it 3 times in a row. And then when we're done, we'll stop and just kind of track and notice. I'll talk you through that. So I'm going to count to 3, and then we'll just do it until you can't breathe. Take a breath and do it 3 times.
Okay.
1, 2, 3. Just be really curious about what shows up in your chest, your belly. Notice if there's any kind of feeling of reverberating or movement. And whatever there is, just let your attention just watch it and be really curious about where it goes. And when you're ready, you can open your eyes, take a minute to kind of look around your room, the window if you have one. So I kind of combined two, but those are the kinds of things that we teach.
I like that.
Yeah. And, just over time, we teach people more and more about how to track that. Mm-hmm. What happens when you notice sensations. And as people get practiced at it, then they can start saying, yeah, I feel like more empty space in my chest. Whereas before it was kind of felt stuffy and full, or whatever.
Yeah, definitely. It was interesting when you told me to drop my tongue. I instantly felt like my whole heart space open.
Yeah.
I thought, well, that's interesting. Yeah. Yeah, I felt it right away. And
it's interesting about the jaw and the tongue because they're the same shape as our pelvis.
Oh, I saw something in that recently.
Yeah. If you tell people to drop your pelvis, first of all, they don't know what to do. And second of all, there's so much wrapped up in the pelvis.
Right.
But if you tell people to drop their tongue, their pelvis will automatically shift.
Oh, that's so interesting.
Yeah. So it's like a whole body experience.
Yeah.
Rather than just the face and tongue.
Oh, that's really interesting.
Yeah.
Is that something with it? It's just like all connected through fascia, or is it like a developmental thing where it kind of developed at the same time?
No. So in my world, it's called diaphragms. So diaphragms are places of horizontal planing where things can get stuck, or if they're open, where things move through. So things being cerebral fluid, fascia, blood, all of that. And so the jaw is one, the pelvis is one, the knees are one, the hip, not hips, ankles are one. And so they're all kind of connected. And so these two are just very, very similar in form and structure. And so they mimic each other. And there's also this, like, I call it hijacking the nervous system, where you do things with your body that tricks your nervous system into thinking things are safer. And we keep our tongue at the top of our mouth when we're stressed. And so when you drop it consciously, the body's like, oh, okay, there's no need to be stressed as much. Same with the vooing. So vooing is like chanting or om. It's stimulating the vagus nerve, which we could talk about.
I know, like a whole nother hour.
Right. But it's stimulating the vagus nerve. And when you stimulate the vagus nerve, it connects with all of the different organs, and the message is all is well. So it's just this little hijack of, it's teaching the body, okay, right now, right here, we're okay. So it's just this like settling of the body because you're doing something with the body that communicates safety.
Yeah. So, again, I feel like this is all stuff we could learn in school.
Yeah.
That we could learn in school. How many of those, like just the vooing, or even, that short little process? I mean, you could do that with kids, at the beginning of the day, couldn't you? Or
yes. So yes, some of the teachers would say that they would incorporate these in their classroom. And so, doing something like vooing in a classroom can be extremely powerful. It depends on the age, right? If you're trying to do it with middle schoolers,
right,
they might not, right? They might make fun of it. They might laugh, whatever. I mean, it's all about kind of norming this stuff, like this is part of our day. And I think if you could norm it in the classroom, you could say, okay, everybody, where's your tongue? Let's just drop your tongue to the bottom of your mouth. And, if it's a routine that everybody's used to, I do think that you could teach some of these to kids.
I think so too.
Kids can't really track very well. It's hard to teach them somatic skills in some ways because it's so abstract, and because we have to unteach not listening to their body, right? So all of us were told, don't cry. You don't have anything to cry about. So all of those messages that disconnect us from the body.
You're fine.
Yeah. Right. Yeah. So it's very, very complicated with kids, but yes, you can do these with kids in a group setting, and it can really help. Yeah.
I do feel like I don't work with kids often, but occasionally I will, and working with my own kids, but I do feel like they haven't contained nearly as long. So they typically can tune into their body faster than adults.
Yes. Yes.
And then
in
that same vein, they release like so fast, so fast.
Yeah. And that's like with the SSP. It has an impact faster because there's not as many layers.
But again, I'm not working with, children that have had a lifetime of trauma either. And, where do you see this going as far as traditional, like, do you see a shift in the more traditional therapy route? Is it getting in there more?
It has to be financially accessible. So the SC training is long and very expensive. And so there's some improvements in that, and that they're, offering scholarships, particularly for BIPOC individuals, because it's historically been a primarily heteronormative white, training that doesn't really address generational trauma and racial trauma. They're trying to make some inroads in that, but they're a little bit behind. And so making this accessible to so many, more people, I'm not really sure, I don't know what the answer is to that. Like I said, Irene Lyon, I think she kind of has hit upon something in terms of being able to offer stuff online for a more reasonable cost, because getting trained as a somatic experiencing practitioner is really expensive. And I just decide I'm just going to take it one module at a time. If it doesn't feel like it's worth it, then I won't do it. And when I broke it up like that, but I had to go to Golden, Colorado 3 times a year.
Yeah. It's expensive to travel and get a hotel and pay for the
What
food.
I would love to see is this stuff being taught in grad school.
Well, that was going to be my next question is like, is it filtering in, are the somatic interventions getting more into the universities, getting into the, the graduate? Not yet.
Not yet. And part of that is because it's not evidence-based, right? And so it's, and I have a mentor in the SE world who says my clients get better. So that's all the evidence I need. Right. And so, but, without the backing of the Department of Mental Health so that you can do peer reviewed research and, it's like all of those hoops that have to get jumped through. It makes it really difficult. I think we're going to have to do it on the down low. Right. And so one of the ways that I do that is, whenever I get invited, I go to Stevens and talk to grad students and tell them what we're doing at HeartSpace Clinic and say, come to your internship there.
Yeah.
And then they learn it.
That's awesome.
Right. Yeah. Then they learn it and then they stay and, then they do their licensure with us and they learn it that way.
Right.
And
it's powerful.
That's, right.
Grassroots.
Yeah, exactly.
Grassroots.
Exactly.
Yeah.
Yep. Exactly.
Well, I don't know. I feel like one of the silver linings on the pandemic is that mental health is being talked about more.
Yeah, totally.
And I'm hoping that, like many things, it pushes the expansion of what's normal to try because there are just too many people that need help right now. And we need more effective therapy. We just do.
Right. Totally.
So I'm hoping that hopefully will be the silver lining on it. And it's just part of the conversation now. And people are getting more curious about, what can I do outside of medication? And I'm not, I'm not against medication at all, but I don't think it's right for everybody. And I think it's probably not right for most people.
Well, and it just masks the symptoms.
It masks the
symptoms. It just, And sometimes the symptoms are biochemical. And so medication is necessary. But, if you're treating anxiety, if there aren't life changes that are made or things that you learn to do differently, then you go off the anxiety medication and the anxiety is still there.
Exactly.
So sometimes medication really helps to kind of bring it down so that you can learn the things.
Right.
And so that,
so you can
that
focus
happens a
and
lot.
actually take in the information.
Right. Yeah. But what you would want is in that situation, perhaps to be able to go off the medication later. If you learn some tools and some ways of kind of
I could
healing.
definitely see that if that was part of the conversation right off the bat, like, hey, let's get you regulated. Let's get you to a place where you feel like you can absorb this information. And then let's try some of these tools. And hopefully at some point you can come off that anxiety medication or depression medication even. But I know it's a big conversation, but I really want to thank you personally for everything you're doing in our community. And this has been a lot of fun. So thank you so much and happy birthday.
Thank you.
Happy birthday.